My name is Jerrold Weinberg. I've been in the practice of obstetrics and gynecology for 19 years. The practice that I entered in 1972 was originated by Dr. Harry Pearse, who I have with me today. Dr. Pearse is 92 years old, and I thought it would be very interesting to talk about obstetrics and gynecology and some of his experiences from 1925 when he graduated medical school up until relatively recently. Just to tell you a little bit about Dr. Pearse, he has two children, Mary and Dr. Warren Pearse, who is presently the Executive Director of the American College of Obstetrics and Gynecologists. But rather than talk to Warren, I thought we would talk to the original Dr. Pearse today. Warren was formerly Dean of the Medical College of Virginia, and before that was one of the professors of obstetrics and gynecology at the University of Nebraska. Warren is a very solid, stable individual other than his irrational love of the University of Nebraska athletic team. Dr. Pearse has 7 grandchildren, all female, and has 5 great-grandchildren, 2 boys and 3 girls. Dr. Pearse, I know that you're originally from Western Canada, and you graduated from McGill Medical School. Why did you decide to go into medicine?
Well, originally I was studying forestry because I had uncles in the lumber business. They had large tracts of timber in northern Saskatchewan. And World War II started in 1914, and I was coming up for draft in 1917. And I had a cousin who was much older than I, and he had a large clinic halfway between Edmonton and Calgary, something like the Mayo Clinic. He did surgery for all that area. His name was Hank Wagner. He was known in the West as a baseball player. And he asked me to come down and visit him. And he told me, he said, you should switch into medicine because you're going to be drafted. And he said, as a medical man, you will probably be a stretcher bearer, and you won't be going over the top at 3:30 in the morning. So I went back to the university. I had to see a counselor, and I switched from forestry into medicine.
And then you graduated McGill in 1925.
1922.
Okay. And then you had to decide which field to go into.
Well, it came about, I had to make money, and I worked in the summers. And as you know, going to medical school, anatomy and physiology are your large subjects. So I went to University of Chicago in the summer, and I got all my anatomy and physiology there. Then when I came back in the winter, I was an instructor in physics at the University of Alberta, and I worked during the winter. And I also taught physics at a girls' college in Edmonton, Lenarthney College for Girls. And the man that we were working with at that time was studying what is now ultrasound or sonar. And the German submarines had to get in close to a ship to sink it. And we were working on ways to detect them at a distance. And Dr. Boyle, being prominent in the field, was called to London. And when he went to London, they had to get a new professor. They got a man about 68 years old from Harvard University, Dr. Hammond. And Dr. Hammond was very good to me. He gave me students to tutor, and he gave me many assignments. And I had examined papers, and he got me in this girls' college, and I made money that way. So I got my elementary part in Chicago, and then when I came back to Alberta, I was given credit for that. And one of my famous teachers there was J.B. Collop, and he shared in the Nobel Prize with banding and discovering insulin. And at that time, Alberta, there was a 3-year course, and your 2 clinical years you had to leave and go either to Toronto or McGill. And I don't know whether you're interested or not, but they all had a club. I was president of the medical club. It's kind of an interesting story. I was president of the medical club, and a man named Logan came up from the University of Minnesota. Dr. Pat Logan had studied dentistry. He practiced 2 years in Minneapolis. He didn't like it. So he came to Alberta and entered medicine. And since he was an American, and incidentally, we had a lot of American students at the University of Alberta, I sort of went out of the way to make him comfortable and so on. So Pat said to me, when we go to finish up, he said, instead of going to Toronto, why don't you go to McGill with me? Because I got some relatives there and in New York. So that's how I happened to go to McGill.
Now, what made you decide to go into OB/GYN?
Well, the one thing, McGill University, as you know, is a real old school. Started in 1821. And in the Department of OB/GYN, they had, I don't know, they had numerous professors. Some I never had a lecture from. But they had a lot of rules in order to graduate. You had to do so many circumcisions, you had to give so many anesthetics, and so on. And you had to spend 2 months at the Montreal maternity. We called it the MAT. Well, Pat Logan came to me and he said, I went to the authorities and they tell me if we go down to New York lying in and spend the summer down there, we can be excused from going to MAT. And he said, I'm going. So I went with Pat Logan to New York lying in. And down there, after being in training for about 3 weeks, we started doing home deliveries. And we covered from 26th Street down to Brooklyn Bridge, north of that Bellevue Medical. So all summer and up into October, I was doing home deliveries for New York lying in, and that got me.
I'm sure modern obstetricians would like to know what sort of equipment you had with you when you went to a home to deliver a baby.
We carried with us, they had a special department in the basement of the hospital. New York flying into a large hospital. And they delivered about 2,000 in the home, and the rest were in the hospital. Now, our bag was set up with a list of things we had to check out, and we had needle holders, and we had catgut. We had ergot, which we never gave until after the placenta was out. We gave a shot of ergot. We carried obstetrical forceps with us, and the other.
Now, when you used obstetrical forceps, what sort of anesthesia had you provided?
Our anesthesia at the New York lying in was ether.
But what about in the home?
We used ether in the home. We would really give them enough ether to just put them under, and as you may know later on, they had a method where the patient held a mask on their face until they had. But we would give them ether till we just got them partially anesthetized, and then we did the delivery.
And the episiotomy repair?
Episiotomy, no episiotomies.
Okay.
And big argument about episiotomy.
There still is.
Still is. Well,
tell us what the argument was about then.
Well, main argument in the home you should do is the least amount of operative surgery possible in the home. Now, we did not have rubber gloves because that cost money. The only time that we had rubber gloves in our bag was if the patient had gonorrhea. And that was checked out when we left. We had to do vaginal examinations, and we did them every 2 hours, and we had to scrub up 10 minutes in the home, and then we filled in the slip, and someone in the family had to take that slip into the hospital. They had some substations. We had to report every 2 hours.
Mm-hmm. Must have had some very frightening experiences.
Well, we used to arrive, those places in New York, they'd have 2 or 3 stories with four rooms on each floor, and you'd have 3 women in labor in one of those places, and you'd arrive, and you were for room 220, and the husband for room 17, he'd be outside waiting. He'd grab you and insist on taking you to his wife, and we used to have some difficulties, and we, once or twice, I did deliveries where we had 2 or 3 policemen holding the patient while they did the delivery.
Mm-hmm.
Police were always available.
And they were helpful to you?
Oh, they were very helpful to us.
Now, these are the days obviously before IVs and before blood transfusion. Tell us how patients got nourishment before IVs. If you operated on somebody, how did you take care of them after surgery with no intravenous?
Well, the first thing was time. We had to operate as rapidly as possible, and we were timed. The operating room nurse would casually say, "You've been operating 45 minutes," which meant you've got 15 minutes left, or 20 or 25 at the outside, and you had to be closed up for that time. And as soon as we were finished, the patient needed fluid. We had 2 ways. We gave them normal saline, hyperdemolysis, under the breast.
How did you do that, with a syringe?
No, we just put we had long needles. We put the long needle under the breast, 1 under each breast, and it went in by gravity drip. The other way was to put a catheter up the rectum about 12 inches or so, and we ran the saline in through the catheter, again by gravity. That was called a Murphy drip. And when a patient is dehydrated, you'd be amazed how rapidly they will soak that up from the rectum. So the Murphy drip was used a great deal and was very good.
Now, was this routine after laparotomy or just...
No, it's up to the doctor's decision.
How long did it take until they would eat usually after, say, an abdominal hysterectomy?
Well, we didn't let them eat for, usually a couple of days. We gave them fluids, forced fluids. Orally, and we kept them in 10 days. And on the 10th day, they were allowed out of bed. And when they were able to walk around, they went home. But there was no early ambulation.
Now, it was the same when you delivered a baby. How long, in the 1920s, how long would a woman stay off her feet after she had a vaginal delivery?
Usually 10 days.
In the hospital or at home, wherever she was?
Yeah, at home. At home we had no control, so they usually were up and around.
Now, what was the reason that you kept them off their feet so long after? What was the thinking at the time?
I really don't know. I was just told that they had to stay in bed, and we never quite... One of those things was... the Mayan Indians used to say it was a costumbre or tradition. We just kept them in.
Well, we still have those too.
I might give you a little sidelight you might
be
interested in. In 1954, when I was in, I read a paper out at the Pan Pacific Congress. Each one of us was given a reel, 500-foot reel, on Hawaiian medicine back in 1800. And This was narrated by a layman. I still have that reel. And after a battle, this layman was off one of the British ships, and he said that he was amazed to see how they got the arrow out of the man's chest. And when they got the arrow out, hemorrhage was called flux in those days. He said to stem the flux, they ground up leaves and placed it in the wound, and next day they made the man walk around, and they kept him walking every day. That was early ambulation by these ancient Hawaiians who did a lot of surgery because they were doing a lot of fighting. The other thing he said was interesting. He said every day they had to sit down 3 times a day and take long deep breaths, which is hyperventilation. He said they told me it was to keep the lung from sticking to the chest. So they had early ambulation.
So, tell us about blood transfusions. When did that get started, and what were the circumstances? That must have been around
late 20s.
Late 20s?
Well, they were doing, I don't know if you're interested in a blood transfusion. They used my blood when I was in the university. Do you want to know about that?
Sure.
Well, we went in one morning as a group of students, and they asked for volunteers to be type. And I'm a type B, and so they used me, and they used the younger method. And the recipient was lying on a couch, and the donor next to it. And they asked me if I'd volunteer, and I was prepared just like I was going to the operating room for surgery. They took my blood pressure all through the taking the blood. The younger method, they had the nurse operate a little set screw, so they drew the blood from the donor, and then they put it into the receiver. And if the blood started to clot, they quickly used a new syringe. And they did that until they had enough blood. But they had me come with a full breakfast, and they gave me half an ounce of whiskey before we started. And when they were finished, at 400 cc's, they asked me how I was feeling. I said, I feel fine. So they said, we'd like to take another 100. This was in the Montreal General Hospital. And when they were finished, I was taken to what we now call the holding room. And the good part about it was I had 2 nurses take care of me for 2 hours. And they stayed there monitoring my pulse and blood pressure. And about 2 or 3 hours later, they let me get up and walk around. And I had a place to go. And they prescribed steak. I ate steak that night. They prescribed a meal for me. I had to stay off my feet to be careful for 2 days. 1 pint blood.
So it was like an operation. They treated it with every possible precaution. Get 1 unit of blood.
1 unit of blood. And when I got in the harbor, Dr. Boleyn did a transfusion once in a while. They set the operating room aside for that. And then they decided they should train somebody to do it so he'd have expertise.
Now, excuse me, when you had blood transfusions in those days, I assume there was no storage. You had to put the donor on one table and the recipient on the other and do it that way.
Direct transfusion. And they had the first anesthetist full-time man, was Dr. Murphy. And they had a general hospital meeting in Harper and decided that all transfusions would be given by Dr. Murphy if they needed them, so he would get expertise. But those also were all direct. And then a gentleman down at Wayne State, a pathologist, Dr. Brines, he learned how to do it, and he made quite a bit of money. He would do it in the home, and I used him a lot. He charged $25 for a direct transfusion.
I mean, he'd bring the donor with him to the home?
Well, I'd have the donor there. We'd have them all set up and so on. All he did was do the actual transfusion.
I see. Now, antibiotics obviously didn't come into being until you had been in practice probably almost 20 years.
That's right.
How did you, we use antibiotics so frequently, take them so much for granted now, especially when we do a cesarean section. Tell us about the fear of infection in those days, and if you would, how you, tell us a little bit about the Waters extraperitoneal section. I know that's how you would try to do a cesarean section so that the peritoneal cavity would not get contaminated.
Well, we always had, in Detroit, there was only one big hospital, which was Harvard. And all of the prominent specialists in Detroit were at Harvard Hospital. So they never had much problem because they watched their OBs very carefully. But in the outlying hospitals, and I did a lot of work at Clinton, most of the women were delivered by general practitioners. And these general practitioners, they would have a woman in labor for 30 hours or sometimes 2 days with ruptured membranes, and when you saw them, they'd have a temperature of 101. And you always had a baby that was fine and so on. Now, the woman must be delivered. And this was routine procedure. We did a craniotomy on the baby. Now, the craniotomy, the instruments were hideous looking instruments. I wish I'd kept mine and gave them away. But we had a scissors called smelly scissors, had a triangular end. And we put that through the fontanelle, and that let the brain out. This sounds kind of terrible. But we let the brain out, which collapsed the head. And then we put the basial tract, it was called. And the inner blade had teeth on it, which gripped into the inside of the skull. The outer blade was smooth, and with that locked in place, we locked it down. We would then pull the baby out. If you had trouble with the shoulders, we reached in and fractured the clavicles. And so that was called a craniotomy.
Now that generally would take care of the infection. But what about when you had to do a cesarean section?
Well, number one, you couldn't do a cesarean section in a neglected case because those women all died of corpus sepsis. So we did the craniotomies, and the slogan was, you make a mouth temper out of her. And the next time around, she'll deliver baby number 2 and 3 without so much difficulty. So Dr. Waters at Margaret Haig Hospital,
what city was that?
That was in New Jersey.
Uh-huh.
And Dr. Waters began doing what came to be known the Waters extraperitoneal section. Now, he really didn't conceive the idea. Dr. Cartwright in California thought of the idea. And he did a lot of dissection on cadavers until he thought he had it down, but he never popularized it. But the Margaret Haig Hospital, they picked it up, and they started doing them. Nobody in Detroit did a water section. And I wrote to Dr. Waters, told him I was in a position where this was a procedure I needed to do. There was another section called a lateral approach. It was very difficult and nobody really did it. Once in a while you'd hear someone doing a lateral, but it was not popular.
Mm-hmm.
And Well, Dr. Waters told me he didn't want to send these movies because it might get lost and so on. And I called him on the phone and I told him I really needed to know how to do it. And I didn't have time to come to Margaret Haig. And so I told him I'd insure the film. So he sent me the film. And Dr. Art Rutson was chief resident at that time at Britain. We had 6 men. We were qualified or certified for 6 residents. And Art Rutson and I ran that movie at least 20 times. We studied it and studied and studied it, and finally I said to Art, I think we know how to do that. And the first house girl, this would be an unwed mother, the first house girl that is a mandatory section, that's the cephalic disproportion. We will do a water section on it. Now, in the water section, we changed the water sections. And as soon as you start doing something, you learn some new tricks. But water said that to find the delineation where the peritoneum attaches to the bladder is very difficult. So we'd open the abdomen, and he used methylene blue in a bottle, and he had one nurse run the bladder. And when you want the bladder filled, she'd hold this up, and it'd fill up with this blue, and it demarcated the tissue as well. And then when you want the bladder emptied, she'd let it down and drain the bladder for you. So you had one nurse to run the bladder. We call her the bladder nurse. And I said to Dr. Rutson on the first operation, I said, if we may accidentally make a hole in the bladder, there's no risk to that, because we might try that. I said, we're going to have a mess with this methylene blue all around. But anyway, when you had this up, you could see the attachment. And the trick was that you went just above where the peritoneum attached to the bladder. And you used a sharp knife and you went across and made an incision. And you cut down until you saw the blood vessels on the bladder. That was the layer you had to be in. When you got down to that layer, you very carefully, with your fingers, you very carefully strip the peritoneum off the bladder. And then you raise, the nurse would fill the bladder, and then you'd come up and you'd keep stripping it until you got behind and it dropped off. Now there are 2 horns of peritoneum that go down into the pelvis. You had to get those off on either side. And when you had that off, you had the peritoneum free from the bladder. You just tucked it up and the uterus was exposed. And we did a transverse incision, in which at that time nobody did. They all did vertical incisions.
You did a classical section?
No, we didn't do classical. That was the difference.
Okay.
We did a low, like the low cervical and with a transverse incision.
Uh-huh.
Yeah, everybody did a vertical incision on the low cervical.
Okay.
We did a transverse incision, got the baby and placenta out, and as soon as they were out, the bladder girl, she filled the bladder up. You could see the demarcation. We just attached the peritoneum with 3 or 4 sutures, closed the abdomen, that was the deal.
You didn't close the wall of the uterus?
Oh yes, we closed the uterus. We closed the uterus and the placenta out, and so.
So obviously the trick was, the goal was to not enter the peritoneal cavity, because if you did, she had peritonitis.
If you entered the peritoneal cavity, you got peritonitis. And the first 3 we did on house girls who were just needed routine sections. They were not candidates, you see. And we found out then that we accidentally opened the bladder. And instead of using methylene blue, we used normal saline. I said to Rutson and Bob Swanson, I said, we can see that demarcation. We don't need methylene blue in there.
Now, did that ever become a part of your practice, a standard part of the practice, doing waters sections?
Well, I was the only one doing them, because At Harper, they never had an indication. So I started getting calls, and Dr. Cushman, who was a well-known, a good plastic, GYN plastic surgeon, Cushman gone. Dr. Cushman had a couple of cases, and he called me, and so I went and did them for him. And he, of course, he worked with me. And then my partner, Dr. Henderson, I did 2 or 3 for Harold. But Henderson was a very good surgeon and a very rapid worker. He was ambidextrous. He could work well the left hand, the right hand. Just didn't have any trouble. After doing 3 for Henderson, he said to me, I knew how to do that better job. He said, just open the abdomen. He said, and you don't have to go through all this bladder business. He said, just open the abdomen. And he said, with the abdomen open, you peel the peritoneum off the bladder, and then you sew the peritoneum up. You don't get infected till you open the uterus. So he started doing them that way. Well, we would only had done a few of those when penicillin came in. And when penicillin came in, waters went out the window. No more water section.
Now, what were the indications? You said there wasn't any need for cesarean sections at Harper. There wasn't any need for a section for infected.
Well, the men at Harper, they had what was called a trial labor. And that was 24 hours. And if a woman hadn't delivered in 24 hours, she got sectioned. And if her membranes ruptured, they sectioned her before she got infected. So they were always ahead of the problem, and they didn't run. Now in the other hospitals, the cesarean sections were all done by general surgeons. The OB men, they did obstetrics, and if they had a patient needed a section, they called surgeons in. And at Harper was discussion where 1 or 2 doctors had surgeons and they were being pushed in the corner all the time. Finally, they gave up the idea and they turned, instead of having a general surgeon do their section, they turned it over to another OB man to do the section.
Mm-hmm. Now, when you went into practice, were obstetrics and gynecology together? Weren't they separate fields at a certain point in history?
They were separate fields, and I came out of Johns Hopkins University. The head man in Johns Hopkins was Dr. Williams, who put out Williams Obstetrics, and the head man in gynecology was Howard Kelly. Howard Kelly changed my life.
Yeah.
I met him, he changed my life.
How did he do that?
Well, he came to Detroit to give some lectures, and had an evening banquet at Statler Hotel. And Dr. Kelly's talk was how to practice medicine and live. And I might interpose here that after that lecture, I worked that up and I gave that lecture numerous times, and I was paid what was considered a good fee, $75. I gave it to University of Michigan travel clubs, and that was the topic, how to practice medicine and live.
Sounds very interesting. I'd like to hear about that.
Well, Dr. Kelly said, all of you men practicing obstetrics in those days it was solo, you took care of your own patients. He said, you're up 24 hours a day. And he said, you shouldn't do that in gynecology as well. He was from Johns Hopkins. He said, if you're going to do it, he said, you should take a month's vacation every year. I don't mean going out to a golf club. He said, I mean you go out and away from Detroit and so on. Well, after the lecture, I went up. He said, Dr. Kelly, I enjoyed your talk, but I don't have any money. And I said, I'm starting out with another man. He's going to give me $100 a month salary. And I said, how can I go away for a month? And I'm trying to build up a practice. And he looked at me, he said, you're a graduate of university, aren't you? And I said, yeah. He said, where'd you graduate? I said, McGill. Well, they were very close because William Osler and McGill, he really started Johns Hopkins.
Right.
He said, did you ever do any public speaking? And I said, yes, I took a course in that at McGill when I did. Just had a chance. Well, he said, you travel. And he said, if you don't have the money, you borrow it. He said, do you have a car? I said, no. He said, how are you getting the car? Well, I said, buying the car and a down payment, and my partner, I said, I'm going in with it, loaning me money. All right, he said, if you can't afford it, he said, you borrow the money and you take the vacation. And he said, if you have trouble getting it, tell him Howard Kelly told you to do it. Because he was well known. And he said, when you travel, don't stay in expensive hotels. He said, stay in small hotels. And he said, interview the hardware man and the local people. And he said, when you come back, he said, you work up a talk. And I started giving travel lectures. He said, were you born in Michigan? I said, no. He said, do you know anything about Michigan? No. He said, you're living in a very interesting state. He says, Beaumont did his research work here, and he said, you got the copper country and so on. So I started out, and he said, he said, you should take off 1 month. When you get 40 years old, he said, then you take 2 months. He said, because you'll be established. And I followed that practice, so I've been practically all over the world and giving travel lectures. And after a time of doing this, it comes around, you have a lot of people. So I did a lot of traveling when it didn't cost me anything. General Motors, and I traveled with, that was helping me, Ford Motor.
Now, one of the experiences you had was you got started going to Central America. I understand you met a priest who convinced you to go with him to visit the Indians in Central America. Tell us about that. And I think you did that for a number of years, and you eventually were working for the government of the United States doing that, weren't you?
That's right. Well, in this traveling that I'm telling you we're doing, we had gone to Costa Rica for a month.
Now, your wife was a nurse.
She was a nurse, and she was traveling with me. And dentist went with me, and his wife was a hygienist. And we did Costa Rica. And for the month in Costa Rica, I stayed at a doctor's home there. And he was the man that got me in the International College of Surgeons, because he met me at some of these meetings. And I stayed with Dr. Rio, and was a guest of the president of Costa Rica for a luncheon, because I took them down some Nidar gun sites, which they could get. That's the sites you put on for shooting ducks. Mm-hmm. And so I was invited to be there. And in those days, you could only travel from one country to another. You couldn't make long trips with propeller planes. And so I stopped in Nicaragua, Revolution, and from there, I flew to Sonoma City. And with all this Central American traveling, I knew the pilots on Pan Am. So I asked the stewardess, I said, Art Baudet was the captain that day. I said, will you ask Art if I can come up in the cockpit and take some shots of the volcano in the Lake Nicaragua? And she came back and he said, yes, he's ahead of time. He said he'll fly around so you can get some good shots and people can look down and see the volcano from the air. So when we finished, he said, you're going to Guatemala City this time? I said, yes. He said, aren't you from Detroit? I said, yes. He said, there's a priest in Guatemala City. Young man, he's been there about 3 months. And he said, he comes from Royal Oak. He said, do you know where Royal Oak is? I said, I sure do. Suburb. Well, he said, you stop in. He's at Las Piadas Church. He said, you stop in and see him. So we did. And had him over for dinner. And he said to me, he said, you know you're an answer to a prayer. He said, we're starting to live among the Mayan Indians. He said, no one's ever been in there. And he said, I went in for 1 week. And they're very primitive people. And he said, they need medicine. And he said, the Guatemalan people don't like us in Guatemala City. So the man in charge of marrying no missionaries, of which the book was over there by Bob Considine. He said, he thinks what we should do is set up clinics. He said, if you could come up and you could get the dentist to come with you, he said, you'll have a 7-hour ride on horseback to get into the outpost. And so he said, he's a really a great man. He said, you'll need some training, he said, on riding before you start. So 7 Mile Road, we went to the stable, and I told the man what I want. We went in there, we rode horseback 3 nights a week in the classes.
Your wife too?
Yes. And we then went down to Guatemala, and we had to drive. I didn't have any airfields at that time. And it was a 2-day drive. We got a driver in Guatemala City. And he drove us up to an outpost called Huehuetenango, which was on the edge of civilization. From there, we went in on horseback.
7 hours.
7 hours to Sonoma. And Dr. Sheppy didn't go every year. But the year following, I went back, and Father McClure said, this time we're going to leave the women in Sonoma. And he said, you and I'll travel, go over in one valley into another one. And he had a new group of Mayans.
So what were their main health problems then?
Main thing were upper respiratory. Saw a lot of good diagnosed. If you wanted really to take medical students, they had everything in the chest you could possibly hear. There was tuberculosis if in there, a lot died of TB. A lot died of pneumonia. And they had no medical care, of course. And no diet. They lived on beans, corn and beans.
Now you took antibiotics with you?
No.
Or was this before antibiotics?
Before the antibiotics, so we didn't have it. But what we did take with us, we took Novocaine. And Novocaine was a great thing. And believe it or not, in their religion, they believed in the laying on of hands. And so I laid hands on hundreds. And ones I loved to lay hands on with the little tots. They would come and bow down, put their hands together. You lay hands on them. And they thought when you laid hands on them that you got a good spirit in there. It lasted a year and a day. So we were laying hands on all the time.
So you had to get back in a year to renew the spell every year?
Well, that was one thing, but we went different places each year.
Now, what did you actually do for them medically? You said something about Novocaine.
Well, of course, he taught Father McClure how to pull teeth. and he took down a blown-up picture of the jaw with all the nerves, and Father McClure became very adept at extracting teeth. That's the only thing he had jars of teeth. They would come in, and patients, 300, 400, 500 waiting for us out in they would come there and sit for 4 and 5 days, and we had no light, and so we just worked from sun up to sundown, and then didn't stop.
What did you do? How did you help them medically?
Well,
were you draining abscesses? Or?
We saw lots of this. We came in, and I remember one woman came in, and I said, well, that woman that got a carbuncle on her hip, she'd walked 2 days. And he says, what are you going to do with it? Well, I said, if she's in Detroit, I turned her over to the surgeon, and I said he would take and excise that whole thing.
Mm-hmm.
Right down to the muscle and clear it up. And they said, we can't do that. So I injected a little Novocaine around the perimeter, and then I lanced it and made sure that they're very stoical. You could do anything to them, and they never winced on the pain part. And drain it, and you should put something on there. And we didn't have any poultices, we didn't have any linen, nothing. We just let it drain to nature.
Mm-hmm.
And how did she get along? Well, never know. You didn't see them again. Except I had them bring me presents. They'd bring in a present of a chicken or something like that.
Uh-huh. So you know you were doing something right. When you came back the following year, they didn't run away from you, so.
Well, it's an interesting case. This woman came in, and her breast looked as if I thought that when I looked at her breast that she had carcinoma, and the whole half of her breast sloughed out. And Ed said, what are you going to do with her? Well, I said, and she had glands in her axilla. I said, well, that's undoubtedly a carcinoma. I said that it's sloughed out. And I said, I don't know whether getting her to Wayway to Mongo would be worth it or not. Now, this would be 7 hours, and they would have to carry her in a chair. And they discussed it. They also had a lot of Indians around, 200 or 300. So they discussed it. They decided after I left to take her down. Well, they took her down, and when they got her down, it turned out that all she had was an infected breast. And she cleared up in the hospital down Wayway to Mongo. And the next year when I went in, Ed says, you're in like Flint. He said, they think you cured her. And she's the chief swine. Chuchkaha, the chief.
So you were in good shape there.
He said, you're in good shape. He said, if you want to go out and visit those stone idols, I'll tell you, you can go out.
Now, after you had been there, I understand the United States government contacted you to get some information for them. This was like the forerunner of the CIA.
Yes, we had a letter from the United States ambassador in Guatemala thanking us for the work we had done for the government and so on and so on. And I was in my office in the Fisher building when a gentleman named Davis, Mr. Davis, came in. He told me that he was with the CIA, and he said, we noticed that you travel a great deal. He said, would you be willing to act as a clandestine news gatherer? And I said, how much risk is there in it? Well, he said, the risk is small, because he said, you're not on a payroll. You're doing this for free. You're not on a payroll, you're doing it for the country. And he said, I'm your boss. He said, you just deal with me. And so on that basis, I said I would do it. And when I was going on a trip after that, I would contact him. Got an office over a bank in Highland Park. He told me, "You never come to my office." He said, "But you may be shadowed." He said, "I will always come to your office in the Fisher Dome." So he would come there, and I did work on parole and different places.
So you would go there to find out how the government was doing and who the enemies of the government were and things like that?
Well, for instance, I'm going to Argentina, and Mr. Davis came in and he said, "Is this trip to Argentina for real or border comment? Is this for real or tentative?" I said, "It's for real." And he said, "Well, I'll tell you what I want to know." He said, "We've loaned her own $40 million. And he says, "See if you can find out what happened to that $40 million. Number two," he said, "how real is the opposition to Perón, and who is it? Is it in the country or out of the country or both? See what you can find out on that category for us." And he said, "Any other information? Those are the two main things we want to know." And he said, "Number three, if the opposition is fairly strong, are they planning a revolution? And if they are, how soon will it be before the revolution?" He said, "Those are the things I'd like you to find out." And he says to me, "And your contacts will all be set up for you."
So in general, you were able to find out some information.
I got all that information.
Now getting back to, that must have been very scary, but I want to talk a little bit more about obstetrics and gynecology. Tell us a little bit more about internal pedalic versions and breech extractions and things like that, and your approach in those days.
My internal pedalic version was an operation that was very popular. And I've forgotten the man's name in Buffalo, but he was known all over the United States. He delivered all babies by internal pedalic version.
You mean when a baby was coming down cephalic?
Yes.
As I understand it, they would give the woman some ether, which relaxed the uterus. They would push the head up into the pelvis, grab the feet, and deliver it as a breech. This was originally a cephalic presentation that was converted to a breech, and if I remember my reading correctly, this was done for cephalopelvic disproportion. And the thing I could never understand was how the head could come out backwards if it couldn't come out forwards with the same diameter.
The saying was that the after-coming head was easier to deliver than the oncoming head.
Okay.
That was the slogan. Now, you had a right posterior that was wedged into the pelvis.
Okay.
And there were some criteria after you would learn how to do it. Number one, the woman had to be, I used to say, I want complete anesthesia. They had to be as deep as for doing a gallbladder, because you want perfect relaxation. And number two, they had to, the cervix had to be completely dilated. You couldn't deliver through an undilated cervix, which a lot of men try to do, you know. Then they got tears, you see.
Sure.
But you need complete dilatation, you need complete anesthesia, and we didn't wear a regular hospital gown. We had what we called shoulder gloves. We pulled a glove on, went right up to our shoulder, and we call those aversion gloves.
I think I saw those when I first went to practice. They had some around there.
Yeah, they come right up to your shoulder.
Right.
Now you put those and you lubricate those with green soap, and you can shove your hand up in the uterus and so on. And I instructed lots of students on that. And the important thing was you put your hand up in the uterus, and you came down over the baby's back, and you don't do this rapidly, too slow. And you came down and you got your fingers between the baby's legs. And you slowly got them so you had the baby feet. You got a firm grip on the baby's feet. Now when you had a firm grip, of course when you went in, you pushed the head out of the pelvis. You dislodged it. And now your assistant up on the abdomen, he had to turn the shoulders. That was important. Flip over for you. So when you did this, the baby just slipped around and came down. And the next important thing was you got the shoulders out by anterior rotation. Put a warm towel around the baby, and we turned the baby around, and we used to say, you turn till the navel points to the sky. You turn the baby right slowly around till the navel was up, and the shoulder would slip out underneath the pubic arch. If it did, you very slowly turned it right around the other way. You could turn it 3 or 4 times, and after you turned it, if it looked like it, you put your finger in, and sometimes now you got the shoulders up. You have this head to deal with. Now most men try to deliver the head in the AP position.
Right.
That's not the way to do it. If this woman was a right posterior, you swung the head in the right oblique diameter. You drew it down to the right oblique diameter. If she was a left position, you put it in the left oblique diameter. And you brought it down through using what you learned as a Morris or smelly blade maneuver.
Right.
And the assistant up top, he pushed straight down on the head, pushed it to the pelvis.
Uh-huh. Did you use forceps?
Yes. There were special forceps. If you got the head down in there and you were having trouble, then we would put forceps, or long forceps, like a low forceps.
Yeah.
We put forceps in. That was called forceps on the after-coming head.
Right. Right. That's how I was taught in 1970 to deliver a breech.
Yeah.
Now, what was a Braxton Hicks version?
That I'm not familiar with. I never did Braxton. Well, Braxton Hicks version, yes.
Wasn't that for placenta previa?
Well, Braxton Hicks, I think that was to do with the version inside the uterus. Convert it. You had a breech. You try to convert a breech into a vertex. I think that's Braxton Hicks.
What was it called when you had a placenta previa and you would reach up and pull down the baby to tampen out the head against the placenta? Familiar with that?
Well, we used to do that, but I didn't know that it had a special name.
I think it did. Okay. Getting back to your career, who were the greatest teachers that you could think of?
Well, number one, of course, was when I had the picture, Dr. George Camperman. And when I came to Harvard, you brought up an interesting point. When I came to Harvard in 1922, obstetrics was separate from gynecology. And Dr. Camperman had been appointed chairman of obstetrics. And the gentleman who was chairman of gynecology, I had been there about 4 months or 5 months. He had a gastric ulcer, and he died of gastric ulcer. And when he died, they then changed the Department of Gynecology over to Dr. Camperman. And that was the beginning of OB-GYN as one department.
Mm-hmm.
But when I came there, they were separate.
Now, you said he was the best teacher that you were involved with.
Well, in college, I had a lot of good teachers in that named Gill. I had a lot of famous names. But James Goodall, never had a lecture from him. But I have a book from him on purple sepsis. And James Goodall was a man who really worked out adenomyosis. In our days, we call them adenomyoma. And but he worked the thing out, and as you know, the idea in adenomyosis, Samson theory was that during menstruation went through the fallopian tube, but Rio Meyer, who escaped from Germany and was up in Minneapolis, Dr. Meyer was the one that really did the final work on adenomyosis. So we got to understand what the disease really was.
One other thing I wanted to ask you, in Detroit, a lot of men in the, I believe in the 1950s and 60s, or maybe the 40s, started to use diethylstilbestrol to treat various problems in pregnancy. As a result of that, obviously, we've seen many problems with the offspring. You were right at the center of that controversy in those days. What made you decide not to use diethylstilbestrol? What can you tell young physicians about new methods and new techniques and a general approach to that sort of thing?
Well, one idea, I'd have to back up a little bit, on medical education in Michigan. There's a story on medical education. In the University of Michigan, they formed what they call the Extension Department, and they asked me if I would be a teacher on that. And they would give us a topic, and they would send 2 of us in the spring and 2 in the fall. And we went to Lansing one night, and the next day we go to Grand Rapids and give our lecture. Then to Parkview Hotel in Traverse City, and then to Winona Hotel in Bay City, and then home. And when I would start out on this, my chief over there would call me in. And he'd say, "Now, Pearse," he never called me Harry. He'd say, "Now, Pearse, you're going up to talk to all these men in these small towns. Don't go into big detail